chat.
Okay.
I will be there on. I am representing both IMA and sorry.
Okay.
Okay, ma'am. So with all your permission, I'm starting the session. Good evening and a warm welcome to all the dignitaries present here. Myself Rupsha from ClearNet, assigned as a session assistant to ensure a seamless experience. ClearNet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for doctors. It's with great pride that ClearNet is the digital partner of this event organized by All India Ophthalmological Society, Odisha. And the topic of today's session is OSOS celebrates World Glaucoma Week. So let's begin today's session, for which I would like to invite Dr. Sarmishta ma'am. Over to you, ma'am. Kindly proceed with your talk.
Thank you, Rupsa. I would request President OSOS, Dr. Subal Kishore Karo, sir, to kindly welcome everyone, and then we proceed with the program.
Thank you. Very good evening to all of you. Today, OSOS is observing the World Glaucoma Week in collaboration with Glaucoma Society of India and IMA. Honorable guests from IMA, Odisha State, Dr. Shyam Sundar Khandelwal, President, IMA Odisha State, Dr. Mrutyunjay Mahapatra, Secretary, IMA Odisha State, and Dr. Brajakishore Das, Additional DMET. Our co-chairperson, Dr. Srimanta Behera, Secretary Dr. Samit Patra, our Scientific Committee Chairman Dr. Sarmishta Behera, the learned panelists, moderator, and speakers from GSI. I welcome you all to this webinar today, and I request our Scientific Committee Chairman Dr. Sarmishta Behera to go ahead with the program.
Yes. Sir, over to Dr. Samir, the Honorable General Secretary of OSOS, to kindly introduce the guests and the panelists, and then we go over to the program. Hello, Samir. Unmute yourself.
Ma'am, is it audible?
Yes, audible.
Thank you, ma'am. Good evening to all the dignitaries over here. And I am Dr. Samir Patra, working as Secretary of Odisha State Ophthalmic Society. And it has been great privilege and honor on my part to introduce all of the eminent guests of the today webinar. The Odisha State Ophthalmic Society celebrates the World Awareness Glaucoma Week. So, guest sir, today the Professor Dr. Brajakishore Das, born 1969 with MBBS qualification and PG, C certificate of NCC, that's great. And with academic position from 2001 to 2020 and 24, continuing from different variety of medical colleges from as associate professor, assistant professor, and professor. And he has been live member of Indian Medical Association, Indian Academy of Forensic Medicine, Indian Society of Toxicology. Different positions held by our Professor Brajakishore Das, Honorary Secretary of State from 2020 to 2024, Director Hospital Board of India 2018 to 20, State Finances Secretary, President Medical Legal Society of Odisha 2016 to 2018, Vice President IMA Cuttack Branch, Joint Secretary of Indian Society of Toxicology, and a member of Central Council of IMA Headquarters 2006 to 24, still now continuing. He has many areas of interest, like from forensic pathology, study of suicide and study of natural death, and academic activities. I am a best state secretary in the year 2020 and 2021. I am a president appreciation award in 2019. Numerous publications in industry journal, guest lecturers, and national IMA award for the best branch secretary in the 2009. Many accolades, many presenters to our professor. Now, second, I would like to introduce our IMA president of Odisha. Dr. S.S. Khandelwal is a very active member and founder of IMA Mayurbhanj for more than 35 years, a private practitioner with multi-specialty hospital, namely Durga Nursing at Baripada, involves himself in a social and philanthropic activities, practicing as a chest specialist and ultrasonologist, recipients of awards for IMA activities of the state, national level, awards from Ultrasonology Association, Social Services, and Lions International too. The next guest over here is our beloved State Secretary of Indian Medical Association of Odisha, Dr. Mrutyunjay Mahabharata, who is an eminent gynecologist, and who has been the director of Medicare Cuttack, former additional director of Health and Family Welfare Department, Government of Odisha, past secretary of AOG of Cuttack, past chairperson of HIV and AIDS Committee, FOXI of 2017 to 2019, and past finance secretary from Indian Medical Association. So these are the eminent guests. Thank you, madam. Hope we'll continue to start our program. Thanks.
Dr. Asmita will moderate today's program. She is doing her fellowship in glaucoma at LV Prasad Eye Institute, Bhubaneswar branch. Over to you, Dr. Asmita.
Thank you, ma'am. So, with the commencement of the Glaucoma Awareness Week, it's a great initiative by the OSOS to create awareness, not just within the patients, but also within the clinicians ourselves, update ourselves about glaucoma. And without wasting much time, we will start with our first speaker, Dr. Sumita Mahapatra, ma'am. I would request her to, ma'am, kindly share her slides and commence with the presentation.
Okay, good evening, everyone. So, as we are celebrating the World Glaucoma Week, we have to know first what is glaucoma. Glaucoma is a chronic progressive optic neuropathy with multifactorial risk factors characterized by loss of retinal ganglion cell, leading to corresponding change in the optic nerve head, retinal nerve fiber layer, and visual field. The raised intraocular pressure is only a risk factor, though it is the only modifiable risk factor, but it is not the defining one. Without raised intraocular pressure, and all the raised intraocular pressures are not glaucoma. So it is only a modifiable risk factor, not a defining one. Then what is the definition of glaucoma? It can vary with the perspective of the definer. To a scientist, it is the retinal ganglion cell apoptosis. And to a clinician, it is the optic neuropathy. And for a patient, there is fear of blindness, because almost half of the population know that glaucoma will lead to ultimately blindness, and they are only to cataract, but cataract is totally curable, but the glaucoma is not curable, though it is preventable. So glaucoma is the leading cause of irreversible but preventable blindness worldwide, and it accounts for almost 8% of the global blindness. Burden of the glaucoma blindness. In India, the burden of glaucoma is 11.9 million, and prevalence of blindness is 8.9 million. The glaucoma contributes to 12.5% of the blindness in India, and over 90% of the glaucoma is not diagnosed in a developing country like ours. And at the presentation to a tertiary center, it was found that 40% of all eyes with glaucoma had advanced stages with MD worse than 20 decibel. This shows the importance of the glaucoma. And to classify glaucoma, it can be classified as either congenital glaucoma or adult glaucoma. Congenital developmental glaucoma, it can be primary, secondary, and primary adult glaucoma can be primary open angle or primary angle closure. And similarly, secondary glaucoma can be open angle or angle closure. And open angle, we can have pre-trabecular, trabecular, post-trabecular, depending upon where the site of obstruction is. And angle closure can be with pupillary block or without pupillary block. To treat a silent disease like glaucoma, we have to know the certain risk factors. Age is the number one risk factor. More than 60 years people are 6 times more common than their younger counterpart. The raised intraocular pressure is also very important as an important risk factor. Then thin central corneal thickness is also important risk factor for glaucoma. The family history, if there's first degree relatives, that is sibling and parents, if they have glaucoma, then the patient is 4 to 9 times more risk than glaucoma. Trauma to eye is also very important for development of glaucoma. Use of systemic or topical steroid is makes a patient more prone for developing glaucoma. Myopia is more common in open angle glaucoma patient, and hypermetropic patients persons are more common for angle closure attack. Then certain systemic conditions like diabetes, systemic hypertension or hypotension, and vasospasm, migraine, obstetric sleep apnea, all these are risk factors for development of glaucoma. So we have to know first, why do people go blind for glaucoma? It can be either delayed diagnosis, that is failure to detect at an early stage, and after the diagnosis is made, if the treatment is inadequate or improper, then also there is risk of blindness. It can be delayed at the patient's level, or it can be missed diagnosis. And non-compliance to the treatment is another important factor, because glaucoma is a very silent disease. The patient will not get immediate benefit and he will be non-compliant to the treatment. So comprehensive eye examination is a must. In a mass screening study in Sweden, which was done, it was found that newly diagnosed cases of glaucoma, as high as 17% had seen an ophthalmologist in last 2 years. And it is not due to the fault of the patient always. This is shown from the study. And proper assessment of the optic nerve head and angle configuration, if not done properly, then it will lead to misdiagnosis and missed diagnosis. So that those two conditions are also, and recording intraocular pressure along with the recording of the intraocular pressure makes the comprehensive eye examination. Then there are certain case scenarios we face. These are not very uncommon, like an elderly man who come for a glass prescription and he got a best corrected visual acuity 6/6. Then he is sent back home because everything is all right. Either the intraocular pressure is not recorded or it is less than 21 millimeter mercury. But the patient comes back with 0.8 cubic and arcuate scotoma. So what has happened in this case? Too much reliance on the intraocular pressure. 21 is not a magic number. Patients can develop glaucoma less than 21 millimeter mercury, and patients also more than 21 millimeter mercury, not necessarily glaucoma. So undue importance to the 21 number is not important. And also the patient's optic nerve head was not examined. And another group of patients, they present with headache and they are treated either as migraine or sinusitis. Sometimes they are sent to the opticians for presbyopia correction. They go to any specs shop, any optical shop, and got their presbyopia correction. But actually they have subacute angle closure, which will manifest to a chronic angle closure glaucoma with very less amount of vision. Then that can be prevented if we do a proper angle evaluation by gonioscopy. And third group of patients also, they are diagnosed as case of glaucoma because their pressure, intraocular pressure was raised, but it was not controlled. So another medication was added. Still it is not controlled. Still another anti-glaucoma medication added until the patient lands up with a counting finger 1 meter vision, 0.9 cupping. But here the mistake was the angle was never looked out. The patient actually have angle closure glaucoma, but they were diagnosed as open angle glaucoma. Though they are diagnosed as glaucoma, diagnosis is correct, but the variety of glaucoma was missed. Only one laser peripheral iridotomy would have been sufficient, but the patient landed up with this much of vision and gross cupping. So this we can avoid if we do a comprehensive eye examination. So then what are the challenges that we face in the 21st century? Number one and important challenge is to find the undiagnosed cases. In a developing country like ours, almost as high as 90% are undiagnosed cases, and only 10% are diagnosed cases which we are treating. And so our challenge is to bring these undiagnosed cases to the diagnosed level. And for that, till then, we cannot rest in peace. And early detection is very important, because in the glaucoma continuum, we can see that there is undetectable disease in the first step and asymptomatic disease is the next step. The undetectable disease we cannot detect, and at least at this level, but asymptomatic disease, at this stage, if we diagnose the patient, then patient will not have functional impairment. So this is the very important stage for stage to be diagnosed. And if the patient reaches the functional impairment stage, then the patient's quality of life will be hampered. So we have to prevent this stage and we have to diagnose it at the asymptomatic disease. And proper and management should be there so that patient will not reach the functional impairment state. So can we screen glaucoma? Because it is a very important silent disease. So can we screen glaucoma? Population screen is not feasible. And IOP is not a useful screening test because IOP high may not always indicate glaucoma, or low IOP will not rule out glaucoma. And targeted screening of at-risk groups we can do, like the family members of the glaucoma patient. We have to make them conscious that they should get themselves examined. And opportunistic screening, like finding asymptomatic cases as they present to the eye professional for other reason. Like in diabetic retinopathy camp, we can at least look at the optic nerve head and see that if there is neuropathy. And also cataract case, the patients are cataract are coming from the camp. On the other eye, we can examine and detect some of the undetected glaucoma cases. With the use of the artificial intelligence, the future holds good because they can detect the perimetry and everything. They can be done easily at a campsite, and we can diagnose a lot of undetected glaucoma case. So we are celebrating the World Glaucoma Week. It is a global initiative of the World Glaucoma Association. It is to raise the awareness on glaucoma, and goal is to alert everyone to have regular eye checkup to detect glaucoma as early as possible. This year, the World Glaucoma Week is from March 10th to 16th, and the theme is Uniting for Glaucoma-Free World, which focuses on the communities worldwide to fight together against glaucoma blindness. If we are together and we fight together, we can beat this sneak thief of sight, because glaucoma is called the sneak thief of sight because it takes away the vision without the patient even knowing it. So that is called sneak thief of sight. For that, combined effort is necessary, and definitely we can beat glaucoma in future, at least less the burden of the glaucoma. Thank you.
Thank you so much, ma'am. The assessment of the risk factors and the necessity of screening, not just at the patient, a single patient level, but also a more wider range community level, that has been a very significant contributor towards decreasing the load of glaucoma. So now we will, after this presentation, I would like to invite Dr. Pranamita Pujari ma'am for her presentation on glaucoma diagnosis. Ma'am, please share your screen and start the presentation.
Hope my screen is visible. Is it visible, Asmita? My screen is visible?
No, ma'am, you haven't yet shared your screen. Just your video is visible.
Okay, one second. Now it is visible?
Yes, ma'am, yes.
It's in slideshow mode, no?
Yes, ma'am. It's in the slideshow.
Okay, thank you. So, good evening, everyone. As we are celebrating Glaucoma Week, this talk of mine is not for ophthalmologists, but for medical fraternity at large. So, like Madam says, glaucoma is the silent thief of sight. The reason is 90%, 95% of glaucoma is asymptomatic till the last stage, and there is irreversible vision loss when the glaucoma is diagnosed. So, if you see, this is a patient with normal vision, and this is a patient with early glaucoma, where there is peripheral visual field is altered. And this is an advanced glaucoma. In the end stage glaucoma, the vision is tubular vision. So the patient only see the center and the periphery is lost. Now, the only way to diagnose glaucoma is directed history taking and a comprehensive eye examination. This slit lamp machine is enough to diagnose a case of glaucoma. You don't need very sophisticated machine. Only with the help of the slit lamp, all the tests can be performed and you can diagnose glaucoma. So, Madam has already told about the history taking. So, while diagnosing a patient, history is important, especially the family history and the steroid use, and if the patient is using high power glasses, if there is history of trauma or any systemic disorder. As the definition say, glaucoma is a chronic optic neuropathy where there is typical structural damage in the optic disc and there is functional changes in the visual field. So we have to look at the optic nerve, the visual field, and here raised intraocular pressure is a risk factor, but it is neither sufficient nor necessary for the diagnosis. But IOP is considered an important factor because it is the only modifiable risk factor which can be treated. We cannot treat the optic disc or the visual field, but IOP we can treat and we can prevent glaucoma. That's why IOP is important in glaucoma. Now, in clinical examination, we have intraocular pressure, pachymetry to measure the central corneal thickness, optic disc examination, gonioscopy to see the drainage angle by which we classify the glaucoma as open angle, closed angle, visual field examination, and RNFL analysis. Now, intraocular pressure, if you see, it's a statistical which is skewed towards the right side. So average intraocular pressure is 15 plus minus 2 standard deviation, and there is diurnal fluctuation also. So the paradox is IOP can be low and there can be glaucoma. That entity is normal tension glaucoma, and IOP can be high, but that cannot be glaucoma. That entity is known as ocular hypertension. Now this is the machine. There's the Goldman applanation tonometry with which we detect the IOP. This is the biprism which applanates the cornea, and we see the Myers. And when the Meyer is opposing here, we take a reading of the intraocular pressure. There are other machines also like non-contact tonometer, tonopen, and rebound tonometer. But before labeling a patient as glaucoma, the IOP should be checked with applanation tonometry because this is the gold standard. About the optic nerve examination, slit lamp biomicroscopy is a must with a 90D or 78D diopter lens. With the slit lamp, with this lens, we can see the optic disc and diagnose what is the change in the optic disc. And with this machine, we can take a optic disc photography and see. So this is the optic disc picture where, so we have to see the scleral ring. We have to see the scleral ring, the rim color, the retinal nerve fiber layer, then parapapillary atrophy region, then optic nerve hemorrhage are present. So these are the 5R which is followed while examining a optic disc. Now, this is the next examination where gonioscopy is done to examine the drainage angle. This is the 4-mirror gonioscope which is touched at the cornea, and with that we see inside the eye to see whether the glaucoma is open angle glaucoma or closed angle glaucoma. If we can see all this structure, then this is an open angle. Suppose posterior trabecular meswork is seen in 180 degree, then this is an open angle glaucoma. And here we cannot see any structure. This is a closed angle glaucoma. Now, other investigation is a pachymetry, that is the central corneal thickness measurement that is done with a probe. This is important because we are appending the cornea, the central cornea part. So the thickness of that part is important so that IOP we get the reliable IOP reading. So if the cornea, central corneal thickness is very thick or very thin, then IOP measurement can be erroneous. Now, talking about the visual field testing, this is the perimeter machine where we get the patient data is entered, the age, sex, his refractive error, and everything is entered, and we got a report like this. Here we can see this is a near normal field, and this is a field, there is superior visual field defect. So this is an objective way to assess the function of the optic nerve, because glaucoma is a combination of structural damage which is leading to the functional disability. So this is the way which we can quantitatively assess how much functionally the patient is disabled. Now this is another way. This is the objective way to assess the optic nerve. This is called optical coherence tomography. And here we examine the retinal nerve fiber layer. This gives us idea about the structural damage, and this is an objective way. Here, this is a color-coded diagram where green is like normal and red is dangerous, yellow is borderline. So in OCT, we can assess the optic nerve objectively. But OCT has so many fallacies. So this is done mostly in case of early case of glaucoma, because it has a database, and database is limited to a particular race of the people and particular age group. So if the person is outside that range, then this report can be erroneous. Diagnosis is the key to prevent blindness from glaucoma, but at the same time, I will say the ophthalmologist should be careful about diagnosing glaucoma, because diagnosis of glaucoma is a life-changing condition which can affect the life of the individual. So caution should be exercised before labeling a patient as a glaucoma patient. Thank you all.
Thank you so much, ma'am. Both the presentations, the previous one and even this one, has put up a lot of things in our mind for discussions, and we'll just complete our final presentation and we'll step over to the discussion about glaucoma. So now I would like to invite Dr. Bhagavat Naik for his presentation on glaucoma management in a nutshell. So please kindly share your screen.
Is it visible now?
Yes.
Okay. Good evening, respected dignitaries from the IMA and from our OSOS, dear seniors and colleagues. So as both the presentation already done with glaucoma, what is, and the diagnosis part very well. So I will say about management in a nutshell. Basically, my presentation is, as Dr. Paramita said, basically to all the physicians, not very deep into the management, surgery, etc., because it is for the general physician also. So what glaucoma management, we includes diagnosis already described, and we have to fix a target IOP. Target IOP basically according to the stage of disease, age of the patient, and the that is CCT, central corneal thickness, and the severity of the glaucoma. And we have the options of medications, lasers, surgery, and after that, if all this fails, if there is a very less visual potential or absolute eye, no perceptual light eye, when there is a painful blind eye, we go for cyclodestructive procedure. That is ciliary body, ciliary epithelium process ablation procedure, so that at least the IOP will be reduced if vision not improved. And target IOP basically it depends on the according to the severity of the glaucoma fix, like mild, moderate, severe, like low 10, and around less than 14 like moderate, and for the mild less than 18, and for the severe I told 10 to 12 millimeter mercury. Our target IOP fixed like this, and accordingly we add the medication or do laser or surgery according to the patients and patient affordability and the individualized customized way. So we'll come to the medications. These are the medications we use nowadays, because previously only pilocarpine, that is myotics, were there. Nowadays there are various like there are umbrella of medications. Still, I have put what we are using commonly. Still, there are some drugs on the underway or in the research, and some are coming also. So PG analog, prostaglandin analog is the that is most effective. It decreases IOP of 33%, 35%. So that I put in first, and beta blockers, that is timolol, betaxolol, etc. And carbonic anhydrase inhibitor like estazolamide, it can give systemic also. It can put in topically like dorzolamide, brinzolamide. Myotics, we have very old drug, very less cost. That's why some maximum company are not making it, but we need in very important times during surgery also, and during laser peripheral also, and some last drug is a to add on drugs like pilocarpine, alpha agonist like brimonidine, etc. And the newer drug which has been FDA approved some recent years, like Rho associated kinase inhibitor, ROCK inhibitor like netasudil and ripasudil. So coming to the mechanism actions, I will not go very details, because how they decrease the IOP. Some increase the outflow facility, like trabecular meshwork outflow facility. Some increase the avascular outflow facility, and some decrease the aqueous humor productions, aqueous flow. So these are the three ways the medicine can work. And this is the new drug Rho associated kinase inhibitor, ROCK inhibitor, that netasudil enhance trabecular meshwork pathway, decrease aqueous humor production, and decrease epicyclar venous pressure. It is the three mechanism, and some say that it is a neuroprotective also. So these are some mechanism actions. And what is the problem of medications? medications, if we reduce the IFB medication, there is no need for go for laser or surgery. No, not like that. Medications have their own like problems like drug intolerance, that is some compliance issue. There is very high cost. That means cost means 2.5 ml prostaglandin analog. It can cost like 450, 500, 600 rupees. So each patient will put 3 to 4 drops like 1. That means 1500, 2000 per month cost. Availability issue also. So these are some drug intolerance. You can see that the drug allergy. So patient not tolerate, this type of medication. So either you have to stop or change the medications, or we see for the other options. And why there is a compliance issue in glaucoma, there is very much, all know that it is very much compliance issue, because patient has to put the medications is lifelong, and the frequency of medication like morning, evening, daytime, nighttime, 3 to 4 medications, forgetfulness at old age. There no assistant, non understand the importance. Patient can skip the medication. If patient comes to the doctor, he will think that he will not put medication for 3 to 4 days like this. Here is a patient I have kept for the example like this. Patient has stopped medication since 4 days. Now the pressure is advanced glaucoma and 33 pressure. You can see that 3 drops he is putting, and there is 4 molecules. So it is not easy for us also to put the other medication in time. So these are the complaints in medications. We have a study. You can see that socioeconomic of long-term glaucoma therapy in India. Here in the low-income group, up to 123 times of their monthly gross income can go for glaucoma management. It is not only the direct cost like medicines only. It is the indirect cost also involved, like their travel, their stay, loss of wages, and patient accompany persons also, their cost. So all included in that study. And one of the highest that is cited paper, this is. So we have to think about this also in our developing country to Indian country. No one can put like 4 to 5 drugs at a time and for a long term, like his whole life. And I have put knowingly this drug issue, because as here the general physicians are involved also. Here we had encountered an unusual cause of recurrent apnea in an infant. We have published in that means in a journal pediatrics. Why I put, because as someone told, why we are doing glaucoma awareness among doctors in other group. Because I say if you do in the community glaucoma awareness, it is well and good, because our doctors also doesn't know what is glaucoma, how the compliance issue, the cost is, etc. Because here one child from Baleswar, I'm not taking any names, etc. That has been prescribed. That means brimonidine prescribed to this 6-month-old child congenital glaucoma. And then after that, patient has come to another government hospital in Kotak, then Bhubaneswar, then in the AIMS, because patient stay of 14, 15 days in ICU because it is central apnea. And they had in ventilator, they had done all the tests, MRI, EEG, etc., etc. So someday they sent to us, as patient has told that glaucoma is there, to another checkup. So we saw that, and even first time I also missed. Then after a thought, I thought about the brimonidine. I checked again that brimonidine. So as we stopped the brimonidine, after 1 day, you will believe the patient got that means relieved from all the things. Patient come out from the ventilator. So they have published this in pediatric department. So I want to say that both the pediatrician and also our ophthalmologist, they should know. You know that less than 6-year-old brimonidine should not be prescribed. Even we should know that in pregnancy which drugs should not be prescribed, etc. All we know for the awareness purposes, I have put this slide because this is very important. Medical legal case could have been happened. Okay. So after that, medications, as you know, medications cannot complete your treatment regimen. So lasers, first I have put NDAG, laser peripheral iotomy, because it's very much important. I will come next slide. This is for angle closure disease. Laser trabeculoplasty for open angle glaucoma, like pseudoexfoliation, pigment dispersion, and open angle, where you can see the angle, we can put the laser to the trabecular meshwork site so that the filtration process increases, enhances. Then the laser filtration surgery, excimer laser, that is another thing, newer technique. And in the last, continuous diode laser cyclophotocoagulation to ablate the ciliary process to complete the siege that is aqueous secretion. And the newer one is a micropulse diode laser cyclophotocoagulation. As you heard that in many conferences that the new term, because it is a on-off phenomena. It gives a less energy, so that the less side effect. Okay, I have put this YAGPay one slide here. I will not go to detail or ledger. Here, I thought this is very important. Here, what we do here, basically we made a hole of 150 to 200, 300 micron in peripheral iris by this Abraham iridotomy lenses. That in the operative procedure, in slit lamp, we can put this lens and we do ledger. In which cases, primary angle closure diseases, and primary angle closure suspect where there are some indications. And we do both therapeutic and prophylactic way. Therapeutic means in angle closure, prophylactic means other eye if you're not developed glaucoma, or in the primary angle suspect cases. Basically, if this has been done in many cases, we could have prevented the glaucoma in our OPD tertiary center. If you feel sad that no one has prescribed this, otherwise the patient could have been saved the vision. Patient now no PL, hand movement, closed face. Due to only this laser can prevent the glaucoma. Other laser I am not this laser, because I will show this to the general physicians also. If you see someone, you are other specialist, okay, but if you just as a discussion I'm going, you can put some torchlight temporarily, you can see that the nasal iris is not visible at all. From the pupil, the light is not going. Here also the same patient. Now another patient, from the temporarily I am putting light, there is nasal iris total not visible. From pupil it is not going. That is, and this patient I am saying it is angle closure, acute angle closure of 60 millimeter mercury. Patient came from the Baripada and admitted here for the 4 to 5 days to decrease the IOP, and at last we did the YAGPay etc. in both eye, and we could save this patient vision, and without that means damaging the optic nerve, at least optic nerve is 0.3, 0.4 still now. And so that is a simple laser technique that can prevent the angle closure glaucoma in future. Here for the example, I have kept this to the others, because from when we are putting light from this side, here you can see the other side of iris is visible. This is the poster of yesterday, so I put for the example purposes. Okay. To the systemic disease control, as Dr. Sumitra Mahapatra Madam told, diabetes, hypertension can lead to this neovascular glaucoma. So as a general physician or other diseases, endocrine disease, etc., they should see that, they should know that it is not about the other, that like only diabetic retinopathy or hypertensive retinopathy. This final complication can be like this. This patient has no PL, absolute way. From the Bhubaneswar, we had captured this. This was a very good image. We have captured this, and this is neovascular glaucoma and steroid in glaucoma. The management also should, in management, I should put this because. Sorry. Okay. So steroid, as we are giving arthritis, asthma, so steroid, we should send this patient to the at least the evaluation for the IOP baseline and the treatment follow-up. Like you are sending diabetes patient to the for the diabetic retinopathy. So the glaucoma surgery, congenital glaucoma, goniotomy, trabeculotomy plus trabeculectomy. We said trap plus trap. For adult glaucoma, trabeculectomy, the treatment, the standard procedures are still now glaucoma valve surgery, minimal invasive glaucoma surgery, and cyclorestorative procedures. So as all the ophthalmologists, you know, so this is the congenital glaucoma. For the general physician, I have put this is the ophthalmic eye, the hazy cornea, large cornea. We can do either this goniotomy to cut the angle by goniotomy knife, or also microcatheter trabeculotomy. So the sclems canal we put this, and this is the Ham's trabeculotomy. We can put this into the sclems canal also from the both side. So this is trabeculotomy, and this is the trabeculectomy surgery where we make a partial thickness sclera, and the aqueous humor comes from the posterior chamber through the iridotomy into the subconjunctival space. Where you do uncontrolled IOP on maximum tolerable medications, advanced visual field defect, progressive visual field defect, with the target IOP still advanced disease and poor patient compliance. Patient cannot afford medication, we have to go for the surgery. And this is the thing. And this is the ideal surgical results bleb. This would be ideal bleb like this, but this doesn't happen always. So there is failure of surgery maximum, not maximum times, like 30 to 40% of the times. So in between, there's another surgery, the minimal invasive glaucoma surgery, they're coming nowadays. So this is the eye stent. That is the smallest device in human body, that is implanted with 350 micron height and 230 micron breadth. And this is the hydrous microstunt. It can put into the sclems canal through the tabula can put into sclems canal. That their result is coming encouraging. They are basically in open angle glaucoma. When we are doing phaco in combined surgery, we can do that. And other also there are many MIGs like bent, bang, and gut, etc. So I'm not going detail for the example purposes. This is can the smaller here the thumb. This is the size. This you can see. And when primary surgery fails or in complicated scenario, we do the glaucoma valve surgery and like this is the AGV and also cyclophotocoagulation, micropulse diode laser and cyclocryopexy cryotherapy also to freeze the ciliary body epithelium to that will damage to the ciliary body epithelium. So these are the probe etc. for the laser probe and example. So to conclude, basically as Madam Hall already told, so just for the last slide I'm putting family history, age more than 40, they should screen like diabetes, hypertension, high hypermetroma, small cornea, myopes, they should go for screening, diabetes and other systemic diseases, and judicious use of steroid from the general physician purpose of view. If you are using, it should refer to the patient for the IOP at least. And at last, uniting for a glaucoma-free world, it was a very nice initiative by OSOS and IMA and GSI. I must give thanks to all. Thank you.
Thank you, sir. It was a very enlightening presentation. I think now we'll ask the panelists to have a discussion on all the inputs that were given on the presentations. Dr. Sangamitra Das ma'am, are you available, ma'am, here?
Yes. Am I audible?
Yes.
ma'am.
Good evening.
Good evening. Good evening, everyone. Actually, all the speaker has touched on most of the important topic, but for general practitioner, few of our suggestion is we know main concern of glaucoma is a blinding disease and it is causes irreversible blindness and bilateral blindness. All the three important, very important. And the same time, it causes asymptomatic blindness. So that means like it is like our fraternity, all doctors, ophthalmologists and glaucoma specialists, we have to do proactively something to detect more and more glaucoma patients and also treat them adequately, timely. It is very important. So there is many studies so that like if you screen general population more than 50 years, 4% will have glaucoma. So it is a big load in the community. We cannot like it is very difficult from only glaucoma specialist, only ophthalmologist to detect glaucoma. So it really needs glaucoma awareness and like more and so this and one point is glaucoma is causes irreversible blindness and asymptomatic. So proactively we have to detect. Second point is we have to detect more and more glaucoma. And another point is we have to detect to decrease the actually world free of glaucoma is not possible. We can united together to do something to decrease the burden of glaucoma blindness in the society. So that is we can do what we can do. We can detect more and more glaucoma patients, and we can try to detect more and more glaucoma patients in early stage, so that like visual deficit and all the problem will be disability problem will be solved. And like there is a lot of study we have and a lot of discussion. Finally, we have done that we cannot go to the community, we cannot do the community screening to find all the glaucoma patients. So we believe in opportunity screening. That means whichever patient is coming to us, we are detecting, and it is only possible like comprehensive eye checkup. It is not like only glass checkup. And so we have to see the pressure. As already discussed, there are so many equipment involved. So glaucoma detection is also not detection, and also staging of the glaucoma. Everything is very critical. So I think like first important is detecting more and more glaucoma patient is important, and it is possible by us in opportunities clinic. In clinic, you can detect like whichever patient coming to us, we can do comprehensive eye checkup and detect glaucoma more and more cases. And same time also we can do some opportunity like high risk patient as already discussed, like more than 50 years. Then patient with diabetic, refractive error, steroid, history of steroid, you can do the opportunity screening there. Another thing, a point I was thinking, this World Glaucoma Week, 1 week per year, everyone will be increase awareness of glaucoma. Awareness will help in one way. Like if our doctors friends will know about the glaucoma, at least they can tell more and more people like more than 50-year glaucoma risk is there, it causes blindness, so they can go for comprehensive eye checkup. Like as after 50, everyone is going for a health checkup. They should come for in the same time, they should come for an eye checkup. And we'll do comprehensive eye check, detect glaucoma, stage glaucoma, and we can adequately and timely treat glaucoma patient. That is one important. Another is we know the family history of glaucoma is very important. Any patient with family history of, any person with family history of glaucoma, like blood relation having glaucoma, they should 100% without fail, they should go for annual eye screening for glaucoma. So that is one important. Another is we can, as discussed, like we should have AI able, like with non-mediatic fundus camera available. So in the field, we can do community screening for glaucoma. And now in our state, like in Cuttack and Bhubaneswar, many glaucoma practitioners are there, many setups are there. We are treating glaucoma. But we can give glaucoma treatment perfectly, but the main problem is detection is more important. And I feel in district level there should be some glaucoma clinic, at least medical management glaucoma should be perfectly done, and all these things. So I think the detection is more important, and also timely treatment, properly treatment, and counseling is very important because it is a asymptomatic disease. So most of the many of the patients we have seen, after explaining everything, they will just discontinue treatment. So previously, for follow-up, I was writing 3 months, 6 months, 12 months, but nowadays I am writing the month and year both, so that the patients are more sensitized. Okay, this is my point view.
Thank you so much, ma'am, for your inputs. Now, I would ask Dr. Rita Das, ma'am, am I audible?
Yes, you're audible.
Ma'am, after all this discussion, I had a question that, like, we obviously population screening or community screening is both practically and resourcefully not feasible for our society right now. But when we think about at-risk group, there are certain things like systemic factors, even ophthalmic factors like refractive error. So how do we bring about the awareness, not just among the patient, but also other practicing ophthalmologists, non-glaucoma ophthalmologists like cornea people who know, who examine the anterior segment, or retina people who are examining diabetic retinopathy, or even a general physician. So how can we have a go together approach from everyone here and prevent this load of glaucoma?
Actually, all of us know, according to WHO criteria, population-based screening is useless. It's not cost-effective. And that's why focusing on high-risk screening. Whoever patient is coming to the clinic, we should do a comprehensive eye examination. All of our previous speakers, they have emphasized on that point. That's very clear. And we are celebrating this week. Main purpose is to make our public and also our fellow ophthalmologists to how to detect glaucoma early, because it's an irreversible blindness and patient doesn't know till is in the end part. That's why we are celebrating is to make our everybody, not only public, our fellow colleague, fellow doctors and everybody, so that we can detect the disease early. Whoever is coming to our clinic, so we should make sure, first thing what I want to emphasize, to examine that person very clearly and do a comprehensive checkup and family history, which is very important to all and every patient. Very empathically we should tell, not that I have written or I have told. I should make sure he or she has understood how important it is. The family history is important. So at least one part, if we'll take, family history is important. So all their family members up to the age of 40 years, they should do one comprehensive eye checkup instead of going for a presbyopic correction. That is one part. And if they have history of injury or steroid or history of myopia, diabetic, all those patients, they should be given very careful examination, and we should make everybody aware, and everybody should be sensitized, and we should be very emphatic on those aspects, and repeatedly we should emphasize through our seminars and through our talks and through our discussion to give importance to detect glaucoma early. That's my point. Family
Yes.
history. And another third point, what I want to emphasize, 99% of patients, because the glaucoma patients are elderly patients and lifelong treatment is required, they put the drops themselves. So that's why there occurs we are telling non-compliance, but they don't have the family members because they're elderly people. Elderly people, the family members, they're thinking, yeah, putting eye drop on them, and cost factor. So many things are there. All of us understand who are practicing, but if we ask each and every patient who is putting the drop, 99% patients they'll tell we are putting the eye drop ourselves. That is the point where we miss we go on adding, but main point, it's not working. The patient is putting, they're elderly people, they have tremor, they have all those things. So we are, instead of giving so many drugs, I would like to emphasize one point in this platform. Please ask a patient, everybody is doing that thing, but to emphasize the point, please ask who is putting the eye drop, because they're not putting it properly. They're costly eye drops, unnecessarily they'll be wasting, and all those issues are there. So we should make aware everybody all these issues. So that are my point in short. Thank you.
This has been a very important point, actually, ma'am, that we not just need to counsel the patient, we just also need to involve the patient's attenders, the caretakers also, for proper control of this disease as well. Now I would invite Dr. Purnima Biswal, ma'am. Are you there?
Yes, I am here. Yes, I am
Good
here. Rita?
Good evening, ma'am. Ma'am, actually, now I would like to ask, like, it's not this screening, not just start at the level of an ophthalmologist. I think the history taking part, as we have stressed so much, it is something which starts with the optometrists, the postgraduates, and even the undergraduations. So how do we think that we can modify our education, the medical education, for not just the future ophthalmologists, but also the optoms, so that the history taking helps us or leads us to an early diagnosis and even an early management?
Yes, sir. History taking is important because sometimes for allergic conjunctivitis, many of the ophthalmologists giving steroids, but not just regular follow-up is required. Even our surgery, we are giving the steroids. People are putting the steroids in between when after 15 days patient is coming, intraocular pressure is high. Some people are steroid responders. So we should check the intraocular pressure. That is most important. And when patient is coming in through the OPD, you should check the AC depth. Every time you should check the AC depth. Sometimes it looks open, but you should do a gonioscopy. It is very important. You may do 2 mirror, but that is not important because indentation is the most important. You should do it first, because I find many of the patients, their angle closure attack or having ocular hypertension with shallow AC. People are doing the surgery. Even when we see in this type of patients, we do the surgery, the complication rate is very high. So you do a simple egg laser iridectomy and check the angle and optic disc, then do the surgery. It is because angle close, if you don't do, the patient will lose the vision. In this way, we should
Yes, ma'am. Yes. And actually, it's also important that while even a posterior segment evaluation, that there's a high time that everyone needs to stress on the evaluation of not just the optic disc, how it is, and the rest of the retina, but also have a clear and strict look at the neuroretinal rim. Because most of the time, while we are evaluating the posterior segment, we comment upon how the optic disc margin, the cup disc ratio, and all, and straight away step onto the retina. But I think neuroretinal rim is also something which should be given stress by every ophthalmologist, glaucoma or not.
Yes, you should know the cup disc ratio, and it is glaucoma. Glaucoma, that is more retina. People are also giving the anti-glaucoma drugs but without knowing the vascular glaucoma, all the cases we should do the gonioscopy. Sometimes angle closure glaucoma, there is the iris neovascularization, and but angle is open. In those cases, PRP, after 3 PRP sessions, we can control the angle closure attack, and we can save the eye.
Thank you so much, ma'am, for your inputs. And I'd like to ask if Dr. Avik Roy is online, sir.
Yes, Asmita.
Good evening, sir. Sir, actually, sir today had a very wonderful speech today at LBPI, and it was a very interactive session, not just for the ophthalmologists and optometrists, but also for the patients there. Sir, actually, I have a question that we discussed so much about medical management, and then we discussed about the compliance and the other things that the expense burden for the patients. So, sir, how do we know the threshold where we should step up or go for means a minimally invasive surgery or any filtration surgery, so as to decrease the not just the economic burden but also have a better IOP control for patients? So how do we regulate that, means have that threshold where we should go for the surgical interventions or just stick for a medical management?
I think it's a very important question. So we tend to monitor the patients. So based on the other the 4 tests that we have done, so should be the combination of all the 4 parameters. So is the pressure is rising, or the disc is changing, or else the angle is becoming narrow? Are there any evidences of angle closure that is coming, or else finally the visual field is deteriorating? And remember, all these changes, the changes can be falsely positive, falsely negative. So like we check your BP or your sugar or your weight, every measurement can have error. So we tend to check all the parameters at regular intervals and check all these parameters with important with important techniques, so that the techniques must be reproducible and dependable. And if all the parameters are showing a definite changes in a single direction, then the patient is likely to be progressing. Then we need to either escalate the treatment with increase of medications, or else going forward to the next step of surgery. And again, keeping in mind the side effects of surgery also. If the surgery fails, we need to have a plan B ready. So like that, and all these discussions must be we need to have a good discussion with these different plans, the patient. And like we always tell the patient that our decisions might change with time. So it's ongoing process. So keeping in mind the outcomes and the results of those 4 different tests, and then reviewing and to take a final call.
Thank you, sir, for your inputs. Dr. Pragya Paramita Mahanti, ma'am. Ma'am, are you online? Ma'am, am I audible?
I think she's not there. You can go over to the next panelist.
Okay, Dr. Sangeeta Basantra, ma'am.
No, she's also not there.
Okay, ma'am.
Naresh sir is there, I think.
Yes, sir. So Dr. Naresh Naik, Naresh Desi Naik, sir. Sir, am I audible?
Yeah. Yes, Asmita, I can hear you.
Good evening, sir. So actually, with the evolution of technology, so how do you think that artificial intelligence and even teleophthalmology, how can they be contributory towards decreasing the burden of glaucoma in our population today?
Actually, the artificial intelligence and teleophthalmology, I don't have much knowledge on that. But one thing can be achieved with that, that is, suppose in a peripheral center where the screening procedures are not there. So there we can have the machines will be there, consultants are not available, the data can be transferred to the higher center. And consultants are there, or the specialist, glaucoma specialists, they can comment on the disease and they can help in the diagnosis and treatment of the patient, where the patient cannot be transferred to the higher center or cannot visit the higher center. So I think that one way it will help, but the simplest thing in diagnosis and treatment is what we have.
Hello.
I think there's a connection issue with Dr. Naresh.
Hello, Naresh. Okay, you can ask someone else.
Madam, let's panel to discuss and the chief guest and speaker. Let them decide some of the topics. Regarding doubts.
You can discuss something with the chief guest.
Yes, that's right.
So Dr. Khandelwal is here, sir. Namaste, sir. Namaste, sir. Hello.
I think he was there. Sir?
Yeah, can you hear me now?
Naresh, we can hear you.
Yeah. Okay, ma'am. So one thing is the direct.
Naresh, Khandelwal sir was asking something. Let's just talk to Khandelwal sir. Khandelwal sir, are you here? Braja sir? Braja sir, are you here?
Yes, I'm there.
Any,
am I audible?
Yes. Few words regarding and all.
Actually, as the first speaker, Subramanian told, this is a very silent killer. Actually, a lot of doctors, we tend to neglect our health of eyes, and when we reach 40, we just go for a presbyopia correction, and that too in a very casual manner. I had seen many of our colleagues going for the regular lenses that's available ready-madely and use it with instead of going to proper checkup. So unless until this is as you rightly pointed out, this being a silent killer, unless until we go for a comprehensive checkup and create more awareness among ourselves as a medical fraternity, forget out from many of the general practitioners and specialists at different level, we tend to neglect of this thing. So definitely this type of awareness, as has been pointed out by the different speakers, needs to be developed among the doctor community itself. Then, and one thing that, as Madam pointed out, that many times ophthalmologists also they are using steroids indiscriminately, thereby masking the disease itself. So we need to have a more proactive approach among ourselves, have more awareness among the doctors and the medical students. As you say, catch them young. Among the interns and residents, we should have some more awareness programs so that we can reduce the blindness caused by glaucoma. Definitely, as has been pointed out, glaucoma-free thing cannot be achieved, but we can reduce the burden of glaucoma. This is a wonderful initiative by ophthalmic OSOS and GSI. So we would like to be today the IMA Barampur branch has got a they have observed in the morning they had a Vakasalon, and in the evening now they have a full-fledged CME. So where the
that we are continuing all over Odisha is being observed, sir.
Yes. So this type of activities need to be done so that we can have a more concerted approach. Thank you and kudos to the whole team for organizing. Thank you.
Thank you, sir.
Sir, Mrutyunjay sir has joined. Dr. Samir.
No, he is there. He is there. He is there, but his video is off. I think he was in a social organized some function. Dr. Khandelwal sir was there. Why I am not seeing his video now?
Khandelwal sir, are you here?
Sir, I think it's not audible.
Any other panelist who is there who would like to speak something?
Can you have some questions, ma'am?
You can take any questions you want to ask.
Ma'am, yes.
Okay.
My question was, I think, Dr. Pranamita, the thickness she was telling about is between 500 to 575. So can we just correlate this thickness with either it is a thin cornea or the thick cornea? But actually, there are many cases where we find the intraocular pressure around 25 to 20 to 25. But in that case, when you go for CCT, we find some cases we find high thickness, some cases we get low. So can we just correlate that the thickness will be more in this open or angle closure? Can you just correlate? That's my question.
Actually, central corneal thickness in IOP, that doesn't have a normal distribution. There is no linear correlation. Means I will say that you cannot say the CCT is this much, so IOP will increase this much. There are different studies, and roughly they say suppose you take the average corneal thickness as 550, then 100 micrometer difference will cause around 7 millimeter change in IOP, thinner and thicker side. So if the IOP is 25, it depends how much CCT is. Suppose CCT is on the higher side and optic base and everything seems normal to the patient, like you can observe till 25 pressure also. Mostly the quarter border will be 26 and 28. So it's a like you cannot say that even now people are using corrected IOP also. That is also not correct, because like I said, it's like not a linear relationship. It's not like if it's X, then it will be 2X. It's not like that. That's why. So thick cornea will be a protective factor and thin cornea is a risk factor. Where a glaucoma suspect, if you suspect glaucoma and it has thin cornea, then there is a major risk factor to observe the patient frequently. That's the thing.
Thank you, Pranamita. Any more questions anyone wants to ask?
Yes, ma'am. My second question to Bhagavata. Dear Bhagavata, does how this do you think that these rock inhibitors are neuroprotective? Have you seen or?
Sir, basically, to your first question, as you asked about, there is confusion. Actually, many times the patients, young patient comes with 20, it's such a 25 pressure. 25 pressure. Actually, in Indian scenario, we think the central cornea thickness 520 to 540 micron at the average. And if we check his CCT is 625 micron, it can happen. Some last week we got a patient 620 micron. So directly, as Dr. Pramita is saying, right, but as a rough calculation, 107 millimeter mercury, we can reduce 7 millimeter mercury, like the pressure will be 17, 18. So if the disc is normal, etc., you can go for a visual field, although baseline as that's better than medical, so I did it. But you can observe so that at least you are relieved that you are not in a danger zone. Then after that you can. So we as ophthalmologist take it as 100 micron to 7 millimeter mercury and average cornea 520 to 540 micron. Accordingly, plus minus. To the second question, sir, rock inhibitor, it has been written. That means it has the multiple actions as a mechanism. We are now using in as a add-on medication in many cases in secondary glaucoma also. The proof we have not got, I have not got, but it is written in literature and mechanism action.
I will add to this, Samir sir. I'll add to this, the best neuroprotection is decreasing the IOP, and prostaglandin analog is the best molecule which decreases IOP to the maximum. So none of the drugs which you know in glaucoma are neuroprotective. In studies have proved that none of the drugs have neuroprotective effect. So like prostaglandin with the must, that is because low IOP is the most, that is the thing which will protect the nerve. So we shouldn't go by that this is a NTG case, we'll go for bimodidine or rock inhibitor. This has not been proved through large RCT till date.
Thank you, Pranamita.
Thank you.
Sir Khandelwal, sir, are you here, sir? We would like to hear from you, sir.
No, he's busy something else. He was actually traveling. So,
So can we now close down? It's already past 1 hour. Does anybody want to say something else?
so Srimanta sir is there, I think. Where Srimanta Behra sir was there.
Srimanta sir, sir ଅଛନ୍ତି କି? Hello. ହଁ sir କୁହନ୍ତୁ କିଛି କହି ଆଜ୍ଞା ଶୁଭୁଛି ଶୁଭୁଛି sir କୁହନ୍ତୁ ଆପଣଙ୍କ ଭିଡିଓ ଦିଶୁନି sir.
I am very happy.
ଆଜ୍ଞା.
I am very happy. Our scientific team and our secretary, the scientific committee and chairman and the secretary are doing a great job. I have seen so much glaucoma panelists and glaucoma specialists. They are new faces in the arena of our OSOS. So it is a good job. Last time I saw the ROP and today I saw the glaucoma specialist and their discussion. Nicely gone through it. I think we have to do more on that. A little bit more on this glaucoma. It is not actually awareness among doctors. If we want to talk about doctors, we must talk about more detailing. And how far awareness is concerned, that is more important. We must develop awareness. Today I found Samir has done a very nice work at Raurkela, involved the students of different schools. So this type of things have to be done more on for bringing awareness actually. I want Sarmita madam, please do more on this issue and more scientific subjects, and all specialists of different groups must be encouraged in our OSOS discussions and OSOS webinars. You must take care of this. I think you are working and Samir and you are working very nice.
Yes.
And I think this year the scientific topic will be very nice.
Thank you, sir.
Okay, thank you.
Thank you, sir. Thank you.
Sir,
Let's move in.
Sir, I'm going to the vote of thanks. Samir?
Yes. Ma'am, yes.
So, heartfelt regards to the August participants. I'd like to express our gratitude to our esteemed president of OSOS for the warm welcome address, and a special thanks to the inputs of our co-chairperson, Dr. Srimanta Behra. We are honored to have distinguished guests with us today, Dr. Shamsundar Khandelwal sir, who is IMA President Odisha. Unfortunately, because he's traveling, he could not join us here. Dr. Brajakishore Das sir, he is very known to all of us, additional DMET to the government of Odisha. And Dr. Mrityunjay Mahapatra, IMA Secretary, Odisha. I'd also like to acknowledge Dr. Samir Kumar Patras for his introduction of our esteemed guests with precise grace and professionalism. Thank you, Dr. Samir. A big thank you to our moderator, Dr. Asmita, for steering the discussions with expertise and ensuring a smooth flow of the event. She took particular care in this good panel discussion. Our esteemed panelists, Sanghamitra ma'am, Rita ma'am, Purnima ma'am, all the three, let me take this opportunity to say the three beautiful queens of glaucoma of OSOS of Odisha. And then thanks, Dr. Naresh, for your inputs. And thanks to Dr. Abhik Roy for his inputs as well. All of us deserve a round of applause for their valuable contributions and insights shared here. A special thanks to all the members of GSI Glaucoma Society of India for their informative presentations, Sumita ma'am, Dr. Pranamita and Dr. Bhagavat. Your expertise shed light on the importance of glaucoma diagnosis and management, and you enlightened all of us. Heartfelt gratitude to all the attendees who are following our discussion in the live YouTube channel as well. Thanks, Clarinet, for your continuous support in giving us this stable platform. So to end my talk, let us stand united, strong and true, against glaucoma's silent cook with screening, diagnosis, and timely care awareness campaigns to glaucoma group. Thank you all.
Thank you, ma'am. Thank you.
Thank
Thanks,
you.
everyone.
Thank
Bye
you,
bye.
sir.
Thank you,
everyone.
everyone.
Sasmita.
Thank you for
Sarmishta.
extending us the opportunity to host the session. So with all your permission, I would like to sign.
Thank you all, ma'am.
Thank you.
Thank you.
Good
Thank
night,
you, sir.
everyone.
Thank you,
Good night,
sir.
everyone. Thank you.
Thank you, everybody.
Thank you, Rita.
Thank you, everybody.
Thank you.
Thank you, Punya ma'am. Rita ma'am, thank you.
Thank you, sir. Namaskar, sir.
नमस्कार नमस्कार जाओ आपण मग देखिए ठीक
Again.
मोर पुराना गुरु
It
गुड़ाक
was really interesting. Sarmishta told, we are seeing three great glaucoma. All have been my teachers, Sarmishta ma'am. Rita ma'am, Purnima ma'am, both were my teacher during JPM when I had my SIC.
my teachers too.
Oh, that's
My
great.
teachers too.
And
I
Sangamitra
thank,
ma'am,
I thank our president. I thank our president. His co-executives are working very nice.
Thank you
Sir,
very much.
you are a part two, sir. You are a part two. Sir.
Yes,
Thank
sir.
you.
All of us are
Big
together.
thanks to Sarmishta for organizing so nicely.
Thank you,
That's great.
ma'am.
Thank
That's
you.
great.
Namaskar, madam. Okay. Let us leave the group.
Thank you.
Thank you.
Namaskar to everybody.
Thanks once
Yes.
again. Once again, thank you, Sarmishta ma'am. Bye bye. Good night. Good night, everyone.
Yes. Good night. Good night.
Thank you, sir. Good night.
Good night.
Good night.